the first time that I have to speak to an audience of ENT surgeons purely. I won't be going too much into anatomy, but mainly on the physiology aspect or some pathophysiology. So today my talk is about pathophysiologic traits of OSA. So why do humans have OSA? So you can consider our airway as a long collapsible tube. Okay, so there are forces that either cause its collapse or a patency. And because of our need for speaking, so this airway is longer than most other animals, and also we have a floating hyoid bone. And so in order to keep it open, you need very good contraction of the pharyngeal dilator muscles, the genioglossus, as you all know, your ENT surgeon, and also with inflation of the lungs. There will also be some caudal traction to keep the airway open. Now, for the airway collapse, we know that extraluminal pressure, either from the fat or small mandible, can cause the airway to collapse easily. And also, every time when we inspire, the negative pressure can also cause airway collapse. Right. So if you look at this, let me see. Yeah, if you look at this MRI image between a healthy and OSA individual, you can see that the velopharynx is obstructed, whereas the oropharynx is narrow, right? Okay, so let me see. And we can look at the upper airway mechanics using several conceptual models. So my first cartoon already showed the model of a collapsible tube. Another way to look at it is with a fixed mandible, all the soft tissue crowding will result in reduced pharyngeal area. And the last model will be about the airway as a muscular hydrostat. Wait, why is the screen skipping by itself? Sorry. Nope. Yeah, I'm still talking about this. Sorry. Yeah. Okay. So the muscular, in patients with OSA, you can see that within a fixed environment, one compression of the tongue in one location will then require expansion elsewhere. So as a result, the tongue will have to move either posteriorly or laterally. So that's these three kinds of models sort of pave the way for how we look at the anatomy of OSA. And I think you guys know it better than I. So how does CPAP work? So for the A model, CPAP works mainly to it doesn't care too much about the muscles around. Okay, it's just a pneumostat. It keeps, not pneumostat, it's a pneumatic splint. It keeps the airway open. So when I talk to my patients, I usually tell them, it's like a tire, a flat tire. So the CPAP is just blowing air into the airway. It's not going to help you breathe. It just make you, you just have a restored patency of the airway. For the mandibular advancement device, as you can see here, our dental surgeons will tell us, we'll just move the mandibular space, the anterior space forward, and that enlarges the space. And also the third one will be if you have the hypoglossal nerve stimulation. I believe you have a talk on that, and then that allows the airway to be open. Right, so this flow diagram shows the current problematic approach we use in real life. If we follow a patient journey, a patient with suspected OSA may present to a doctor and we'll send them for a sleep study to confirm whether there's any apnea or hypopnea, and then we diagnose sleep apnea. Then what do we do next? Everyone, right? I mean, even the ENT surgeon, right? Send the patient for a CPAP. And with CPAP titration, we hope that, we'll find a pressure. We hope that the patient can tolerate it, can tolerate the CPAP, sleep well. And unfortunately, almost half can't tolerate our CPAP. So what happens when the patient comes to you, they say, oh, okay, then we'll probably need a mandibular advancement device, or you need surgery. And we'll do maybe a sleep endoscopy and so forth. And so other people may, I think that this is the most common pathway. And the sad thing about it is it's try and error. We don't know really what's the underlying cause of the patient's sleep apnea. So how can I move it forward now? So I can use the mouse. Okay. Right. Sorry. Right. So back to the physiology. When we have to keep the upper airway patent, there's this thing called critical closing pressure. So if the upper airway mechanical load is high, if the upper airway mechanical load is heavy, it will tip the balance off, and then the patient's critical closing pressure is very high. Okay, it's usually more than 0. As a result, if a patient's to keep the airway open, you need compensatory neuromuscular response. So a patient with good compensatory neuromuscular response, the disease, we can keep the critical opening closing pressure at least less than 0. Right. So how do we keep our genioglossus contracted? There are three influences. Our steep wake stimulus. The most important thing is the wakefulness stimulus. Okay, our wakefulness stimulus will actually cause the hypoglossal motor neurons to activate our genioglossus. Okay, so being awake helps. Number 2 is the respiratory control center in the medulla. Okay, that also sends output to the hypoglossal motor neuron nucleus, and that also activates our genioglossus. And finally, local mechanical receptors will send message to the NTS, and then so our superior laryngeal nerve also activates our pharyngeal airway. So these are the input to our genioglossus muscle. Now, we all know that to have OSA, almost all our patients will have impaired anatomy. The problem is some have pure anatomy, but a lot of other people will have a combination of contributing factors, such as ineffective upper airway dilator muscles, a patient who gets aroused easily, and also people who overreact, oversensitive ventilatory control. So these 3 factors, may play a part in an individual. So we really need to find ways to understand the underlying physiology in addition to the anatomy. So this is one way that we can find out how strong anatomy contributes to the problem. So, this is one way to measure passive critical closing pressure of the upper airway during sleep. So when the patient is on CPAP, let me see whether I can control the mouse. Can I control the mouse to, oh, maybe you can give me a laser pointer, yeah. This is, okay, so a patient who's on therapeutic CPAP, okay? And then what you do is that you just drop the CPAP pressure for 5 breaths, and you measure how when the flow reaches 0. So for patients with severe OSA, you'll find that even when the mass pressure has not reached 0, the mass pressure is still positive, the flow has already reached 0. Whereas patients with mild OSA, or the pressure had to go to negative, okay, less than -2 before the patient reaches a peak inspiratory flow. So to do this, in the sleep lab, you probably need a special, you need a pneumotachograph, okay, a special device to measure the flow. So we talk about the upper airway problem, the critical closing pressure. How about muscle responsiveness? So this is, again, okay, so in a patient with excellent muscle effectiveness, what happens is that the same thing, you'll give a therapeutic pressure. And when it drops to 0, naturally, your tensor palatini, your genioglossus, they'll act in concert, okay, in synchrony. And so much so that flow is restored, okay, even before your pressure goes back to therapeutic level. So this patient has pretty good muscle effectiveness. But when we look at so if you look at these 2 obese subjects, both of them had BMI of around 35. In the OSA patient, not only is the tongue volume large, the fat percentage is 42%. So could that contribute to poor muscle responsiveness? So this is one example of a patient with very poor muscle responsiveness. So you can see that the pressure here, the therapeutic pressure is about 10. When you drop to 0, there is no response. There's no response in the tensor palatini or the genioglossus, and it only becomes activated when there's a cortical arousal. Okay, so in this patient, the patient, being awake will save will restore the airway patency. So when we look at obese patients, okay, these 2 groups of patients, they are both BMI of more than 25. One group has no OSA, one group has OSA. You notice that actually the responsiveness of patients with who are obese but without OSA, they have excellent muscle responsiveness. Whereas those control subjects without OSA or OSA patients who are obese, they have lower muscle responsiveness. And after we talk about responsiveness, I would like to talk about the respiratory arousal threshold. Now, so we talk about how arousal will actually save a patient, right? I mean, restore the airway patency. So is it a friend or a foe? The thing is, during slow wave sleep, our respiratory arousal threshold is increased, so it's harder to wake the patient up. And it's also during that time when our genioglossus muscle activity is at its highest. So if the patient keeps getting woken up, it can prevent deeper, more stable stages of sleep. And ironically, in OSA patients, the level of respiratory stimuli that are required to recruit pharyngeal dilators and to restore airflow is similar to that level that also trigger arousal. So waking up prematurely limits the buildup of respiratory stimuli, although it activates the pharyngeal dilators to compensate and reestablish airflow to the upper airway. So, and also another bad thing about arousal is that it can cause a sudden increase in minute ventilation. And if we over-respond, the CO2 can be driven to below the apnea threshold. Okay, so then you may see some central sleep apnea. Okay, so this is a patient with a low arousal threshold. You can see that with a drop in pressure, there's increasing negative epiglottic pressure swing before the patient gets aroused. Okay, and so if the arousal had not occurred, actually genioglossus have been working hard. Okay, the muscles have been working hard. It may have continued to compensate or restore without really causing, this cortical arousal and muscle, responsiveness. So cortical arousals can save lives in people with blunted arousal responses, such as those with hypoventilation, because if we want to raise arousal to ensure the patient doesn't wake up so easily, we usually give some sedative. But in patients with blunted response, you really don't want to give sedatives. So in subjects with poor muscle responsiveness or poor neural coordination to the pharyngeal muscles during sleep, you really need the cortical arousal to help. And also, we just mentioned about it being life-saving. So apart from using a pneumotachograph method to arouse, to measure a person's respiratory drive, arousal drive, this is one method used by SANS that they actually use information from the PSG to the ventilation to estimate, okay, to estimate signal. So what I was mentioning before, they're all like what people do in the research lab, and there are increasingly many different groups trying to explore whether can we use a PSG, the data or signals collected in PSG to estimate all those arousal threshold, peak crit, and so forth, so that we don't need to have to put a diaphragmatic EMG or esophageal pressure. So this is also different other methods to measure the ventilatory drive. So finally, I want to talk about the high loop gain. So what is a high loop gain? So in a research setting, if a patient has good airflow and during therapeutic CPAP, if we drop the CPAP for a few minutes, in a normal person with low loop gain, the breathing may peak at about threefold after you restore the CPAP and then return to a baseline. But in a patient with a high loop gain who is very sensitive, the breathing may peak over, up to ninefold maybe, and then because of this over response, the CO2 is driven to below unit level, and so there's a central sleep apnea afterwards. So this is talking about people who who develop CSA when we give CPAP. Yeah, so a high loop gain can lead to pharyngeal airway pressure closure, and sometimes this decreased airflow within the breath, this high loop gain can effectively even suck the pharyngeal airway close. Within breath, there can also be a closure. Interestingly, again, obese patients have high loop gain compared to controls. And we think that the mechanism is probably due to the increased circulating leptin in overweight individuals. So in summary, I'm sorry if I went, go through those models really fast, but we need to remember that among our OSA patients with impaired anatomy, some may just have mild anatomy, like those with peak crit of less than -2, and some with really positive peak crit, they have severe anatomy. And if they have severe anatomy, we can go ahead with whatever surgery or CPAP will help. But those with moderate anatomy, and that's the majority, right? Almost 60%. Some of them have one or more non-anatomical impairment. So this group of people, we need to maybe look for non-anatomical therapy in addition to targeted anatomical intervention. And for those with mild anatomy, these are the ones with, that we really have to look for alternative ways to help them. This is a model used by Danny Eckert's group. They look at peak crit, arousal threshold, loop gain, muscle responsiveness. We're really hoping that they can look for ways that in future when we do a PSG, the PSG will not just give us a AHI or RDI, but also to give us information about these various aspects. Okay, so in his study, he found that only about 23% of OSA patients had severe anatomy, anatomical problem, about 60% moderate anatomical problem. And then for these other people, you may need, apart from CPAP, upper airway surgery or mandibular advancement device, you may need, this is a no major anatomical impairment, but for those with non-anatomical impairment, you may have to consider hypnotic to raise the arousal threshold or oxygen therapy. And for those with loop gain, you may have to try acetazolamide and so forth. This is a busy slide, but it's just to show that there are studies have been conducted for patients with, let's say, with impaired dilator muscle function. You can try upper airway muscle training, the hypoglossal nerve stimulation, even using dicipramine. And for those with low arousal threshold, non-mild relaxant hypnotics, respiratory control instability, oxygen, CO2 stabilization, or acetazolamide. And these are the traditional ways that we've been working on for OSA. So in my sleep lab, what we do is that we'll for patients with we suspect with high loop gain, we'll try ways to minimize the hypocapnia by using a non-vented mask. So some masks have inbuilt exhalation port, right? Exhalation valve. So we use a non-vented mask, and then we add a tubing that is about 100 to 150 mils, and in order for the patient's CO2 to build up. So this is what we do. This is about 150 mils, and then we have tubings of different length. We also measure the transcutaneous CO2 during the study to ensure that the patient doesn't have high CO2 to begin with. So to conclude, we like to understand the underlying pathophysiology of our patients. We really need to understand what's the understanding the physiology will help us personalize treatment according to the patient's physiological requirements. And that really can pave the way for precision medicine model. The reality and challenges are currently the PSG collects a lot of signals, but we, in the clinical lab, we don't know how to use these signals to help us derive more answers apart from the AHI, oxygen saturation, and so forth. So there's some complicated calculations, small formula that you can use to predict who might have a low respiratory arousal threshold, or but if you have with some manipulation, we can actually estimate loop gain and upper airway collapsibility from our current PSG data, but you need a lot of computational expertise and some offline data processing. So we're really hoping that in the future, the industry can come up with machines that are more user-friendly to help us understand more. So future research, we're hoping that there'll be more simplified techniques for us to use in the day-to-day lab, and we hope our patients will truly receive targeted therapies that addresses their physiological traits. And right now, I think that we still have a lot of work to be done to identify our different phenotypic group and see how various treatment can help them. So the future patient may not just have CPAP, they may have CPAP either with the non-vented mask with dead space for those with high loop gain, or you prescribe sedative that is not with muscle, that doesn't have muscle relaxing component property for patients with high arousal, with low arousal threshold, to raise that arousal threshold. And for patients who are pretty mild, send them for either myofunctional therapy training or try the hypoglossal nerve stimulation. And with that, I'll conclude. Thank you.
Okay.